Okay, so let's go ahead and get started. Today we're going to talk about the role of cardiac MRI in stress testing and CAD detection. And so the first question obviously people always ask is, oh, can you really do a stress test in a magnet? And so the answer is yes, you can do stress testing, but obviously it's important that you have all the proper equipment. So you need obviously good EKG gating capabilities. You need a MRI compatible infusion pump, an MRI compatible power injector for contrast administration. You need a way to be able to communicate with the patient. So we have an intercom system with headphones that the patient puts on. You need a monitoring system that's MRI safe. And then obviously you need qualified staff. So it really requires a number of things to be able to do this. Now, what are the different approaches that we have? So what I'm going to try to do is go through and talk a little bit about different potential options, whether we talk about exercise MRI, coronary MRA, Dobutamine MR, and then adenosine or regadenosine MR, vasodilator testing. So there actually are a couple of different methodologies to do exercise testing in the MRI environment. So this actually is an example of an MRI-compatible treadmill that sits next to the MRI scanner. And then once the patient has achieved peak exercise, they quickly go onto the MRI scanner and you rapidly try to acquire images. This is a technique that's being pioneered at Ohio State. And then there's also a company out of the Netherlands that has basically a pedal ergometer. So you would actually have the patient pedal. So it's kind of like a bicycle type while they're in the MRI scanner. The reality is these are all still kind of experimental techniques right now. So this is not what's done in routine clinical practice today. All right, maybe in the future. Now, obviously, when you talk about coronary MRA, for assessment of coronary stenosis, the resolution of MR just really isn't sufficient enough to be able to resolve stenoses within coronary arteries in any kind of routine fashion. But there may be a role for MR when you look at patients who are suspected of having anomalous coronary arteries, and there are several studies in the literature that have demonstrated reasonably good diagnostic accuracy for this application. And especially if these are young patients that you're concerned about radiation exposure with CT, this may be one role for MR. But I think to do MR to try to assess for stenosis within coronary arteries doesn't really make a whole lot of sense. All right, so I think that really the two methodologies that we're going to utilize is Dobutamine MR and then vasodilator stress MR. So how do we do Dobutamine MRI? Well, it's done similar to Dobutamine echo in that you give Dobutamine at different increasing doses. And some of the advantages I think that MR have are that there's no image quality limitations from body habitus or lung disease, that we're able to ensure that we're getting identical matching slices at each stage. And then in addition to that, we can couple that with a direct scar assessment by delayed enhancement CMR. So I'll show you an example of a case where Dobutamine MRI was done. This is a 60-year-old gentleman who has degenerative joint disease and therefore is not able to exercise. He has underlying lung disease, and therefore his primary care doctor referred him actually for a Dobutamine stress MR to evaluate for 4 weeks of effort-induced chest pain. So let me show you what the study would look like. And let's do this. Okay, you guys can all. There we go. Okay. You guys can all see that? Maybe, can we turn the lights out? It's a little bit bright. So this is basically done, again, just think of it the same way that you would do Dobutamine echo. So these are baseline images here, and we've got basically 3 short axis images, basal, mid, apical, and then 3 long axis images as well, a 2-chamber view, a 4-chamber view, and a 3-chamber view. And then this next stage here is at 10 mics. And then as we go further down, well, yeah, that's good right there. 20 mics, and then we've got peak at the very bottom. So let's take a look. Let me scroll back up to the top here again. So looking at the resting images, what do you guys think? Who wants to volunteer? Who wants to be volunteered?
It looks normal.
Okay, so resting wall motion you say is normal, okay? So then this is 10 mics, or I'm sorry, actually you were looking at, I didn't go all the way up. This is rest here, okay? So you say rest looks normal? Okay, this is at 10 mics. And again, what are the things you look for? Same thing in Dobutamine echo, what are you looking for?
Thickening of the walls.
So you're looking for appropriate increase in wall thickening, and what else? Right, and you want to see that the cavity size gets smaller, right, as you go to higher and higher stages. Okay, so what do you think about 10 mics, which is shown here? Okay, everyone says normal, okay. And let's keep going now. What about at, let's keep going down here. This is 20 mics now. Hyperdynamic, okay. So cavity size looks like it's gotten smaller, right, compared to before? Okay. Anybody concerned about anything so far? No? Okay. And then let's go now to peak. Now, I don't want anybody to get a seizure because it's going so fast, but what do you think? You're worried about the apex on the 4-chamber view here, right?
Right.
How many of you are concerned about that? Now, do you see confirmation of that on the short axis view? Right? So I think this may, again, just be where this may just be that you're imaging through a slightly different part of the you know, so you're foreshortening the apex and making it look that way. I mean, I'm not convinced about the apex, but anything else, because you don't see it on the short axis view, right?
So the infra zone and mid-inferior wall. So that lags behind a little bit. Everything else gets thickened and it becomes something like this. And even the septum in the base. You see that.
Now, remember the basal septum you got to be careful about, right? Because you know, if you get up near the outflow tract, and that's why for the septum it's always good to look at the long axis views, but.
But inferior, see 47 is the inferior wall.
Mm-hmm.
That doesn't work.
Okay, and inferior, or you think maybe a little bit more infralateral,
Infralateral to inferior and
Right.
lateral, so there's two segments.
right? And if you look at basically it's this area right here. Does everyone agree with that? It looks like it looks a little bit abnormal, right? So you had basically what looks like initial augmentation and then a worsening, right? That would be suggestive of ischemia. So this would look like this would be an abnormal dobutamine stress MRI. Now the other thing that we have the advantage of also is that we can do scar imaging as well. And this now is our delayed enhancement MRI images. And everyone here is familiar with delayed enhancement MRI and how it works? Who's not familiar with that technique? Okay, so we have several people that are not. So basically this is a technique where you give gadolinium contrast, you wait about 10 minutes, and then you perform imaging, and this actually allows you to directly visualize scar. So areas of normal viable muscle will be black, and areas of scar tissue will appear bright or hyper-enhanced. Now, on these images here, are there any areas that look like they hyper-enhance?
Just a little bit, just tiny bit, maybe because I'm a little biased now, but it's not convincingly, like it is.
Yeah. So there is, yeah, it looks like there is a subendocardial wall motion abnormality in the lateral wall, right? So it looks like you've got an area that has a subendocardial infarct with evidence of inducible ischemia. And this is one of those things where if you go back and look at the baseline images again, in retrospect, let's go forward. Does anybody, could I convince anybody that, well, maybe there's a little bit of a lag in the lateral wall motion at baseline? Right, but it's very subtle, and I think it'd be hard to appreciate that. But yeah, I think this is an example. We would say this looks like this is a person who's actually had an occult infarction, and he's got inducible perfusion abnormality. Yeah, exactly. That little lateral wall there, you can see it, and also on the short axis view, right? Yep. So I think, so the key again is when you look at the baseline images, always make sure you very carefully look to see if there's any areas that don't thicken as well as other areas. Okay, so this is an example of what Dobutamine MRI would look like. Let's go through.
One quick question.
Yep.
In the nuclear world, they talk about a defect size, and they have prognosis outcome data based on defect size.
Yeah.
In the echo world, we talk about a wall motion score index,
Yeah.
and we have some outcome data on that. Is there equivalence of those?
Yeah.
So
So
that if this guy goes to surgery, for example, that you could tell the person, well, it's a defect, but it looks like relatively score of X, and that's probably you have a.
yeah. So yeah. So we do. Yeah, so we can do it the same way we can come up with a ischemic score. In other words, the extent of the left ventricle that's ischemic and the extent of the left ventricle that shows infarction or scar. Now, most of the data, though, has actually really demonstrated, unlike nuclear where they look for a 10% or higher, most of the studies with CMRs I'll show you are really just the presence of any inducible ischemia seems to be associated with a worse outcome than the absence of this inducible ischemia. But I'll go through some of the literature in the latter half of this talk. So if you look at the literature, probably this is one of the largest studies that actually compared Dobutamine CMR with Dobutamine echo. And this was in a cohort of over 200 patients that all got cath and all got Dobutamine echo and Dobutamine MRI. And they basically looked at the sensitivity, specificity, positive, negative predictive value, and overall diagnostic accuracy, demonstrating, in fact, that Dobutamine MRI certainly has a fairly good diagnostic performance, and this cohort had a better performance, in fact, than Dobutamine echo did for detection of inducible wall motion abnormalities and CAD. So there's a couple of challenges, though, with Dobutamine MRI. So how long did that test take? All right? Because if you think about it, for us to have a new test for people to adopt, there's a few challenges that you're going to have. One is you need to be as good at, or really better than, other tests that have been around for a long time that are widely available. So you need to really be superior to stress spect or to stress echo. You need to be able to do this in a fairly quick fashion. Typically, an hour or less would be the goal. And you need to be able to analyze this in a fairly quick fashion as well. You can't say, come back in 2 days and I'll get the quantitative analysis done and be able to give you results. So the goal really is that you want to be able to analyze the images within 10 minutes and come up with an answer. And so that's where I think if you look at Dobutamine MRI, that study takes about 90 minutes to perform. And there can be some challenges with tolerability of Dobutamine infusion while you're inside the bore of an MRI scanner. And then one of the limitations that you have is that we don't have the ability to monitor ST segments in the MRI, right? We can monitor rhythm, but we can't monitor for ST segment changes. So with Dobutamine, where you actually may be inducing ischemia, that's also certainly a concern. So there are labs that do Dobutamine MRI, but you'll notice if you look at the MRI community, over the last probably 10 years or so, the modality which I'm going to focus really on here, which is vasodilator stress perfusion CMR, has really kind of supplanted at most labs Dobutamine MRI, aside from very selected cases. And the reason for that, I think, is just tolerability is a lot easier. So obviously, this is not a new concept, I hope, to most of you, which is the idea that as you have decreasing coronary blood flow, you begin to gradually have a cascade of symptoms or a cascade of abnormalities that can occur. With perfusion abnormality maybe being one of the earliest signs of reduced blood flow, and then things like systolic dysfunction, EKG changes, and then symptoms of angina may actually be later presenting symptoms. So the idea also behind perfusion imaging may be that it may be a more sensitive test because it identifies abnormalities earlier in the cascade. Now, if you look at the physiology of how vasodilator testing works, if you look at in a resting condition, if there's no stenoses, then you've got really normal coronary perfusion to all territories of the myocardium. And for simplicity's sake, let's assume that it's 1 milliliter per gram per minute of blood flow to each myocardial region. And then if you have coronary stenosis present, then over time that may lead to a reduction in resting perfusion. But really, because of the ability of the blood vessels to autoregulate, at 70% and even probably 90% coronary stenosis, you may not have a significant reduction in resting perfusion. Now, if you have a 99% stenosis, you may begin to see a reduction in resting perfusion. But this is where the idea of coupling this to some kind of a vasodilating agent, where you're actually inducing a hyperemic state, so you're actually increasing the coronary blood flow. And so in a maximum vasodilatory state, you may get between 4 to 6 milliliters per gram per minute of flow. And then you'll notice what will happen is, in the resting state, you have a significant increase in coronary blood flow, or in a non-stenotic lesion, I should say. But then if you have a 70% stenosis, then there's less of an augmentation in blood flow in those areas, and maybe your blood flow only increases 3-fold instead of 6-fold. And then if you have more severe stenosis, then you may have even less grades of increase in blood flow. But generally speaking, you're not going to have less blood flow in the hyperemic state than you will in the resting state, even with a significant stenosis. And so that's why, certainly from a safety standpoint, we're less concerned about giving vasodilator agents than we are about giving inotropic agents like dobutamine inside of an MRI scanner, where you have no ability to monitor ST segments. Now, what is the principle by which perfusion imaging is done by CMR? So what we use here, so one is you use some stress agent, whether it's adenosine or regadenosine, to induce a hyperemic state, and then we give gadolinium, which is a T1 shortening agent, and then we use a T1 weighted sequence, which allows you to basically have an increase in signal intensity, which is going to be directly related to blood flow. And so I'll show you an example of what that looks like. So this image on the right-hand side is an example of what a perfusion CMR assessment or acquisition would look like. So you'll notice this is a short axis view. Here's the right ventricle here, and this is the left ventricle here, and this is the myocardium. And let's start at the very beginning. You'll see first there's no contrast. Contrast gets to the RV, then it gets into the LV, and then eventually it gets into the myocardium itself. And what you're looking at is you're looking to see what is the rate at which the contrast enters into the myocardium, because that's going to be directly related. The signal intensity here is directly related to the magnitude of blood flow that gets into that area. And what you would expect to see, obviously, is that in areas that have a coronary obstruction, there's going to be a reduction in the amount of contrast uptake. So you may not have a defect that stays dark the whole time, but you're looking for really a delay in the uptake of contrast, and therefore indicative of a reduction in perfusion. Now, this actually is just showing you, if you look at the individual still frames here, the red arrow represents an area where there's inducible perfusion abnormality due to coronary obstruction. And the green arrow here in the inferior wall represents an area that doesn't have any coronary obstruction. And you'll notice, if we actually were to draw a region of interest here in the inferior infralateral wall, you'll see there's a pretty abrupt increase in signal intensity as the contrast enters into the myocardium. And again, remember, contrast enters into the RV cavity first, then the LV cavity, and then eventually into the myocardium. And then as that bolus of gadolinium transits through, you begin to have a decrease in signal intensity. And then you do get actually kind of a second peak, which is the recirculation as some of that contrast makes its way all the way through the vascular system and comes back. Now, if you have an area here in the anterior wall, you'll notice if we plot out the signal intensity, there's a delay in the upstroke, and there's it doesn't achieve the same peak signal intensity as you see in the remote area. And again, this is what you're looking for as indicative of coronary obstruction. Now, I'm not going to go through all the basic studies that have been done, but there's one I do want to highlight, and this is actually about a 15-year-old study now in a dog model where they looked basically at gradually increasing the magnitude of stenosis and then looked at both MRI flow ratio compared to microsphere flow ratio. And what they found really was that there's a fairly linear relationship here between the MRI blood flow ratio and what you see by microspheres. So there wasn't this plateau effect where as you got to higher and higher flow rates that you actually get a plateauing in the MRI flow rate. And in that study, what they found was that regional differences of twofold were consistently apparent just on visual, unprocessed MRI images. So it didn't require fancy post-processing, but rather could be done just by visual assessment alone. And then obviously, in this study, they also compared, or I'm sorry, this is a separate study that was done by the same group just a couple years later, where they compared the MRI flow ratio in comparison to microspheres with MIBI SPECT, with Dalian SPECT, and then with in and ex vivo MIBI. And you'll notice that with the nuclear-based techniques, there tends to be this plateau effect that occurs, whereas you get to higher and higher flow rates, you begin to actually get kind of a plateauing in the tracer uptake. Now, so I think these were, along with several other studies, were kind of the foundational basis behind stress MR. Now, the other thing, obviously, as we talked about before, is to have this applicable for clinical practice, we need to have, one, a systematic way in which we do the acquisition, and then also a systematic way in which we interpret the images. And so let me show you how the acquisition is done. So this is kind of what a typical stress CMR study would look like. So you start out initially with cine images. Again, you want to look at wall motion. You want to look for ejection fraction, contractile abnormalities. We then will begin a hyperemic state, either with regadenoson or with adenosine. You then inject gadolinium contrast very rapidly, and then the dose here is typically a 0.075 millimole per kilogram dose, given at a fairly fast rate, about 3.5 milliliters per second. So you need to have a good size IV in place, typically an 18 or 20 gauge IV, because you don't want to end up infiltrating. And then you want to follow that with a rapid saline flush. Preparation is the same as you would do with other forms of vasodilator stress testing. And the dose that we use here for regadenoson is the same, 0.4 milligram IV bolus. After you do your stress perfusion imaging, and again, this is done with a gadolinium contrast injection, wait about 10 minutes or so to let the gadolinium dissipate, and then you follow it up with a second set of perfusion imaging, but this is done at rest. And then at the end, we finish off with a set of delayed enhancement CMR to look for myocardial infarction and scar. So the total time here for this is probably on the order of about 45 to 60 minutes. So this can be done, I think, in a reasonably time-efficient manner. Now, when it comes to interpretation, I think there's a couple of things I want to highlight. There's some ways that you want to incorporate the same principles that we do with SPECT, but there's some things that are very different. And so obviously one of the things that I think is analogous to SPECT is the fact that when you do interpretation of your images, you're going to get the highest diagnostic accuracy if you systematically incorporate all available data. Now, what are the available data that we have? Well, remember I said we have cine images, which allow us to look at regional and global wall thickening. We have delayed enhancement images, which allow us to look for myocardial infarction and scar. We have stress perfusion images, and then we also have rest perfusion images. So you want to really make sure that you look at all of these and not fall into the trap of just looking at the stress perfusion images alone. And I'll show you again what kind of a full stress perfusion CMR study looks like. Let's see here. Here we go. So let's take this. And basically, again, you've got, so for a vasodilator stress, you've got a set of cine images. These are our stress perfusion images here. These are rest perfusion images. And then these are our delayed enhancement images. And the way that the techs actually go through and arrange this page here so that all the images are lined up so that this location is the same location as this, is the same location as this, is the same location as this. That way it makes it very easy to compare different imaging sequences at the same location. So we'll come back to this case later, but I just wanted to show this case first. Now, one of the things, though, if you think about, is when we have, 4 different sets of images, you actually have a lot of different possibilities of permutations, right? You could have cine images that are normal or abnormal, delayed enhancement images that are normal or abnormal, stress perfusion, rest perfusion. So you actually could have 16 different combination of results, right? And so that's why what we want to do is when we go through and approach the interpretation, you want to have kind of an algorithm by which you go through and analyze these images. And so this is the algorithm right here, all right? And so you'll notice what we're starting out with first is actually by looking at the delayed enhancement images first, okay? And why is it that we do that? And again, the delayed enhancement images are what show you myocardial infarction and scar. But remember, these are the most high quality images that we have, all right? The perfusion images are lower resolution and lower signal to noise images because you're having to acquire an individual image in 150 milliseconds in time, whereas your delayed enhancement images each are taken over several different heartbeats. So they're much higher quality, much higher resolution images. So we place more weight on those images. And basically then, if you have, and again, this is an algorithm for detection of coronary disease. And what we'd argue with you is that if you have evidence of myocardial infarction, then you've already made the diagnosis of coronary disease. All right, and that's why in this algorithm, we would say if the delayed enhancement MRI shows a CAD pattern of hyperenhancement indicative of a myocardial infarction, you would say this person has coronary disease. Now, this algorithm will be modified a little bit if your assessment is not to identify the presence of CAD, but rather to look for inducible ischemia in a patient who has known coronary disease. Next step then is delayed enhancement's negative, then you go on and look at the stress perfusion images. And if the stress perfusion images are normal, then you say there's no coronary disease, and you're done. If the stress perfusion images are abnormal, then you go on and look at the rest perfusion images, and then what we're looking for is if there's a match defect or reversible defect. Now, stick with me here because basically if there's a reversible defect, we would say there's evidence of coronary disease. If there's a match defect, we would actually say there's no coronary disease. Okay, so that's a little bit different than what you're typically used to in nuclear. When you see a match defect, you would say that's indicative of an infarct. And I'll go through and explain all of this to you in a second. So let's start off with this example case. And again, if we go through our algorithm, we look at our delayed enhancement images first. And what do you see on your delayed enhancement images? Right? So there's an area of hyperenhancement here in the lateral wall indicative of myocardial infarction, because this fits a coronary artery type pattern. It's subendocardial base, and it fits with the extent of it is consistent with the coronary distribution, right? With a circumflex or OM distribution. In this case, if I looked at the stress and the rest perfusion images, they were both normal, right? But again, that's why you don't want to get trapped into just looking at the stress images. On the basis of this, if we stick with this discipline of this algorithm, we would say that this is indicative of coronary disease. And in fact, this person does have a significant obstruction in the obtuse marginal. Okay, now let's go through another example case. And I'm showing you this a little bit out of order here, but I'll just tell you that the delayed enhancement was normal. Okay, so then we went and looked at the stress perfusion, which is on the left here. And what do you see on the stress perfusion images? Okay, so you've got basically a perfusion abnormality, which looks like it's in the anterior septum and anterior wall, right? This area right here. Everybody see that? Okay. How do the rest perfusion images look, right? Because remember, our algorithm here is delayed enhancement's negative. We look at the stress. If that's positive, I'm going to look at the rest and look to see if this defect is matched or mismatched. And how do the rest perfusion images look? Okay, so there's not a matching defect, right? So there's a mismatch here. And if we have a mismatch or reversible defect, then we say there's evidence of coronary disease. And in this person, in fact, and this is just showing you the individual still images, normal delayed enhancement, defect on stress, normal rest perfusion, and this person, in fact, does have a lesion in the left, in the LAD distribution. Okay? Now let's go. Sure. Yep.
The first example you had where it was already scarred,
Yeah.
but then the rest of the stress perfusion images were identical.
Yes.
Does that just mean that there's not a reversible defect?
That's what I'm saying. I think So it depends. Basically, what this is indicative of is that this person has coronary disease. One of the things you have to be careful of with any technique, there's always false positives and false negatives, right? The delayed enhancement technique suffers from very few false positives and false negatives. Perfusion technique, on the other hand, because it's lower quality, lower resolution, lower signal to noise, can suffer from false positives, right? And so that's why, again, even though I don't appreciate any perfusion defect here, I would still say if the question is CAD detection, I would still say by virtue of the fact that this person has an infarct, then all bets are that this person has coronary disease.
But if this was sent for a stress evaluation, you would say.
Right. Yes. Then the way you approach it, if your question is in a patient who has known coronary disease and you're looking for ischemic burden, I would say I don't appreciate ischemic burden in this case. But again, remember there can be false negatives and false positives, right? And so that's why this would have been a case if this was a person who had known coronary disease. You would say this person does not have inducible ischemia, but I think would you be wrong, right? Because there actually is evidence of a coronary obstruction in this territory, right? Okay, so let's go. So we went through this case. Now let's go through another case to keep going through this algorithm here. And actually, before I do that, a couple of things to point out is there are some fundamental differences, again, between what SPECT perfusion looks at and what CMR perfusion looks at, right? So with technetium or thallium, it requires the presence of an intact cell membrane in addition to abnormal perfusion. Whereas with CMR perfusion, it really doesn't require an intact cell membrane. You're simply just measuring perfusion. The other thing is if you look at the resolution of these images, so SPECT is typically on the order of about 10 by 10 by 10 millimeter pixel size or voxel size. CMR perfusion is about 3 by 3 by 8 millimeter voxel size. Now compare that, so that tells you that you've got about a 20-fold higher voxel size or smaller voxel size than you do with PET. But if I showed you delayed enhancement images on the right-hand side, that has a voxel size of about 1.5 by 1.5 by 6. So the delayed enhancement themselves are about 10 to 15-fold higher resolution than the perfusion CMR. And then the other aspect is that the perfusion CMR images have to be taken very, very rapidly in really a span of about 150 milliseconds. Okay, so now another principle that I think is important to understand is that where CMR differs from SPECT is that if you have an infarct, it doesn't give you a matched defect. In fact, an infarct will give you a mismatched defect, right? So let's take a look at this case here. What do you guys see on the stress images? Oops. No. How does the stress images look?
Is it subendocardial?
Yeah, so there is evidence of a perfusion abnormality, right? It's not looping for us, but that's okay. I can.
Subendocardial.
Right, there's LED distribution, perfusion abnormality, right? Okay, how do the rest images look? Do you see perfusion abnormality? Yep.
No.
There isn't, right? And in fact, though, when we look at our late gadolinium enhancement, now one of the things you have to be careful of, right? If you look at the stress images, there's a little bit of rotation on those images, right? So make sure, right, because look at where the septum is and where the RV insertion sites are. So there's a little bit of rotation on this image, but the area where you saw the perfusion abnormality corresponds actually to an area where there's late gadolinium enhancement. And again, that's why you look at with this algorithm, you go with the LGE first, right? Now, in somebody who has known coronary disease, I would compare the size of the LGE to the size of the stress perfusion defect to say, is there a matched defect between the scar or the infarct and the perfusion? Now the question is, why is it that I have a mismatched defect? Why don't I have a fixed defect in the setting of an infarct here? Right, and this has to do with the fact, if you actually take a look at, let me go back, take a look at that area, right, on these images, right, on the rest image, even before I give contrast. Do you notice? Let me pause this here. See that? What do you see there? Look at that anteroseptal wall.
Yeah.
There's actually a slight increase in signal there, right? Why is that? Because remember, I gave gadolinium for the stress. What happens to that gadolinium? Well, most of it washes out of the blood pool, but what happens to gadolinium in areas of infarct? It stays there, right? And so it's just that it's not as appreciable as it is on my late gadolinium enhancement image, because again, this is a much higher quality image. I've given 2 doses of gadolinium when I do this LGE image. So there's more, this is a better T1 weighted image, and it's a higher quality image. But in fact, once you've given an injection, if there's a infarct present, your rest images inherently will not show a perfusion abnormality in that area because they've seen it's seen gadolinium and it's holding on to gadolinium. Okay, so that's why also. Yep.
If a guy comes with an MRI and goes to the cataract, gets stented, artery gets up and nice and the guy goes well, ends up with an area, just an area of epinesis, blah blah blah.
Yeah.
And sometime later, when you get this study, you expect then the stress to also be known.
What?
Because even the stress is done after the delay enhancement.
No. The stress is done first. If you remember the approach that we showed you.
You said no, you do delay enhancement first. That was
No, that's interpretation.
But the
The acquisition. Let me show you the acquisition. The acquisition starts with stress perfusion first, rest perfusion, and then delayed enhancement after. But the interpretation.
What you just said earlier about the leftover of the delay enhancement is not true because the rest is done before the delay enhancement.
Okay, so that's a great question. So remember, I'm doing delayed enhancement images here, but I've given contrast here as well, right? I've given contrast for my stress, and I've given contrast for my rest. And then, so I'm simply doing my delayed enhancement images later, but I've given the contrast with the 2 perfusion images.
How should the stress images look in that example that I gave? The
So-
artery is now perfectly open.
Right,
There's a subendocardial area of a scar.
right.
How would the stress look?
Yeah, so what you'll find in people who have an infarct is it really depends on what what the capillary network is doing. So most of the time the capillary network is destroyed in an infarct. And as a result, your stress images will show a perfusion abnormality which will match the infarct that you see on your delayed enhancement images. So remember, this is a thing, when we're doing the images, right, when we're acquiring the images, doesn't mean that the properties of gadolinium uptake, they occur throughout the course of the study, right? So once you give gadolinium, it will go and start to attract to infarct. So typically, if you have an infarct, you'll have a stress perfusion defect that'll be present, but you won't see a defect on rest. And the reason you won't see a defect on rest is simply because I gave some contrast beforehand. Now, I could flip it. If I did my rest perfusion images first, then what you'd see is that on your rest images, you'd have a defect. On the stress images, you would not, if there's no inducible ischemia.
The first example you show actually had a normal stress. You use scar. The very first example.
Right.
the medium top.
Right, and that's because that's a false negative perfusion, right? This guy has coronary disease, right? This person has coronary obstruction. Maybe it's not functionally significant. It's possible, but the idea is that because if I look at the hierarchy of data that I've got, I place the most weight on this because this is the most high quality images that I've got. These stress perfusion and rest perfusion images, they're taken over a very rapid period of time, so the image quality is not as good. So my confidence in it is not as high.
On a simple-minded approach, I would say this guy has a small infarct, normal perfusion, so his long-term prognosis would be a heck of a lot better than a guy that shows an infarct and also loud perfusion. Now maybe that
Right.
That has not been looked at.
Right. No, and right, no, exactly. And that's why I say it depends on what the reason you're doing the test is. If your reason for doing the test is that you know the guy's got coronary disease, and I want to see if he has inducible ischemia, this is a study I would say there's infarct with no inducible ischemia. On the flip side, if my objective is CAD assessment, I would say this is a guy who's got coronary disease, right? So even though I don't demonstrate ischemia, I would say this guy has coronary disease. And this is where one thing in the MRI literature you'll look at, there's a distinction. In the nuclear literature, oftentimes it's said that if you have a fixed defect, your prognosis is not that bad, right? You know, right, if you have, I don't think that's actually the case. And I think the reason for that is because if you have an infarct, we've got a wealth of data that says if you have an occult infarction, then your prognosis is worse than people who don't have an occult infarction. So I think the fact that by virtue of the fact you have evidence of an occult myocardial infarction, if my objective is risk stratification, this is a person I would put into the category of this is a guy with CAD.
But I don't think there's a disagreement
Yeah.
because in the nuclear data, a fixed defect has a better prognosis than a mixed defect, but it's still not as good as a healthy perfect.
Right. Correct.
There are gradations, so I think probably it's a very
Right.
similar.
Yeah, I think they're different. I think it's just oftentimes people interpret it to say, oh, if this is a fixed defect, okay, it's okay. You know, and the problem with that oftentimes on the nuclear is that sometimes a fixed defect is from artifact, right? Sometimes it's from artifact, right? Okay, so we've gone through these examples. Now let's go. Okay. So then the question becomes, stress perfusion imaging should always be done before your rest perfusion, all right? Because otherwise what will happen is your rest perfusion may look normal, but then your stress, or may look abnormal if there's an infarct, but then your stress perfusion imaging will look normal. Or if there's actually peri-infarct ischemia, then you get these bizarre abnormalities which don't match a coronary distribution, right? And that's why it's always important to make sure that you do the stress before you do the rest. Okay, and then the question is there any reason to do rest perfusion imaging at all, right? And the reason to do it is because rest, if there's a matched defect, so you see a defect on stress and on rest, that actually represents an artifact. And I'll show you an example here. And again, if we go through the algorithm, how does the stress image look?
So for septum, there's a perfusion defect.
Right. You've got a septal perfusion abnormality on stress. How does it look on rest?
Same.
Same. Right. Yeah, I mean, the challenge, yes, so the challenge here, which is, this is a good observation, which is the way that these images are done is we typically get 3 to 4 images throughout each cardiac cycle. So some images are required in systole, some are required in diastole, right? So you get blurring, and some are required kind of in the middle, right? So that's why you have to be careful. And again, that's why my confidence in these is not as high as my confidence in the delayed enhancement. And this person, they have no LGE, so delayed enhancement's negative, stress perfusion shows an abnormality, but my rest perfusion shows a matched defect, and so we would say this is normal, and this person had normal coronaries by cath. Okay, so these are kind of the 4 basic principles, analogous to SPECT in that you want to look at everything, but different from SPECT in that infarct does not give you a fixed defect, it gives you a mismatched defect, and it's important to do the stress before the rest, and matched perfusion defect actually corresponds to an artifact. Okay. Oh, they're multifactorial. So because one is, yeah, you've got motion that's occurring because this slice happens to be acquired partly in systole and partly in diastole, kind of when there's motion of the heart. There's other artifacts called these Gibbs ringing artifact where there's a rapid change in gadolinium contrast. There's RAP artifacts. There's many different artifacts or causative artifacts. Now, the one question somebody may ask, though, is, okay, that's great, but with this algorithm, what if I have severe resting ischemia? Then I have a defect that's present at stress and rest, but actually because there's severe coronary obstruction, am I going to miss that, right? And so the way you get around that, I'll show you a case here.
An artifactual mode.
Yeah. Okay, here we go. Take a look at this.
Mirror image.
Okay. And so here's one case. Let's look at the stress images here. And what do you think? You guys,
Inferior wall,
right?
infralateral inferior.
Right. There's this right here, right? Basically from about 4 o'clock to about 7 o'clock, right?
Mm-hmm.
Okay? That's all my stress. And then the rest, in the interest of time, the rest of the images, that was at the basal slice. The other ones are not that impressive on the stress. Now let's look at the rest image. How's this look? Same. So I've got a match defect. So if I stick to that algorithm, I would say it's an artifact, right? But this is where you have to incorporate some additional data. So before I make that final assessment that this is an artifact, two things. When you look at this defect, does this defect match a coronary perfusion territory?
Yes.
It does, right? And the other thing is, does this defect look like it just affects one pixel along the subendocardium, or does it look like it's almost transmural? It's transmural, right? It lasts for a long period of time. It's transmural. It matches a coronary distribution. Last then, because physiologically, if I have severe resting ischemia, should wall motion be normal?
No.
No. And that's why you always want to go back and look at wall motion at the end. So that algorithm there's one little final caveat to that, which is if you have a match defect, make sure you look at wall motion in that area, and you can appreciate there actually is a subtle wall motion abnormality here in the basal inferior wall. Okay? So the clues here were not just a wall motion, but also the way that this perfusion abnormality looked, it looked very, very real. It looked, coronary distribution, very high, a lot of significant intensity of perfusion abnormality, and it lasted for a long period of time. All right? Whereas artifacts oftentimes won't match a coronary perfusion territory. They'll just be along that one subendocardial pixel. So there's a lot of different things that you look at. So any of these things, there's always nuances to it. Okay? So let's keep going. Okay, so let me skip past this one here. This is actually just some of the studies that are out there in the literature. And in the interest of time, since we're running short, I'll quickly go through these. But this was one study, it's about 4 or 5 years old now, the MR Impact 2 trial, which actually looked at perfusion CMR compared to SPECT-based techniques. And what they found, in fact, was the area underneath the curve for your perfusion CMR in this study was 0.75 versus your SPECT-based technique, whether it was gated or ungated, had a slightly lower area underneath the curve. And I think more important, this study right here, the CE Mark study, which is more recent, which really looked at a large cohort of almost 1,000 patients at a European center that all underwent cath. So these are all intermediate risk patients. They all underwent cath, and they all got a stress CMR and a stress nuclear done as well. And you can see whether you look at all patients based on a 70% cutoff, you look at all patients using a 50% cutoff for significant disease, patients with single vessel disease, or patients with multi-vessel disease. The ROC curve suggests that stress CMR gives you a slightly better performance than was achieved with SPECT-based techniques. Okay. Let me skip past this. And this actually is just some prognostic data, which also shows, again, if you look at Dobutamine CMR, the incidence of heart events for people with a negative Dobutamine CMR versus those with a positive Dobutamine CMR, and the incidence of late revascularization. You can see, again, worse prognosis if you have evidence of inducible wall motion abnormalities on Dobutamine CMR. And let's get past this here. And the same findings for perfusion CMR as well. The one thing you'll notice is that a negative perfusion CMR tends to give you a better negative predictive value than a negative Dobutamine CMR. And that probably makes sense because there's probably some selection bias in the patient population that's getting sent for a Dobutamine CMR versus those that are getting sent for Vasodilator. And then in addition to that, probably makes sense because perfusion-based techniques are probably much more sensitive than wall motion-based techniques are. So let me, and then this actually is just kind of a compilation of multiple studies in the literature, again showing a negative predictive value of about 98.3% for subsequent events after a negative stress CMR study. Let me go through a couple cases here where I'm going to show you the entire case, and I want you guys to go through and help me interpret. So this first case here is a gentleman who 50-some years old with about 6 months of increasing shortness of breath. And he had a plain old treadmill where it only went about 5 minutes. No EKG changes were noted, but he was then referred on for pharmacologic testing. And so again, remember, if we go with the algorithm that we have, what do you want to look at first?
Grid enhancement.
Right, so let me scroll down. Here's your delayed enhancement images. So these are a stack of short axis delayed enhancement. Anything? Okay.
Not impressed.
Okay. So what do you want to look at next?
To look at stress.
Right. So right. Based on the algorithm, we would look at the stress images next.
But just by looking at scenario two, the wall motion.
Yeah. If you want, we'll come back to that at the end. Okay. How do the stress images look? Let me zoom in on these so you can see them better. Anything on this one? This is a pretty basal slice, so again,
I think they,
maybe we can turn those lights out again. Sometimes it's hard to see these. You need a monitor with a good brightness to be able to.
I feel like it's more than just that.
Okay.
Yeah, it's all over.
Right. So let's go to the next one because I think it'll become more clear. How does this look?
So this is like anterior and even inferior wall, septal wall. It's like subendocardial, not transmural.
So it looks like it's going from about 2 o'clock all the way around to about 5 o'clock, right? Okay. This looks like multivessel, right? Now let's make sure we go through and look at all the images. How does this look? Same thing,
Yeah.
right? And this,
Yeah, it's the same exact distribution.
okay. So you've got a large perfusion abnormality that looks fairly dense. Now let's compare that to our stress images. I mean our rest images, sorry. So these are rest images at the base.
There is still some, but it gets better.
Okay. Let's go to the next one. And typically what we do in the lab is I'll pull up 2 screens and so we can look at them side by side, the stress and the rest.
It does improve.
Okay. And so again, if we go through our algorithm here, you would say you think there's no delayed enhancement, and you think there's a mismatched or reversible defect, right? So that would be suggestive of coronary disease. Is that correct?
Yeah.
Okay. Now the question becomes, what coronary distribution?
Looks more than one. It's like anterior and then septal and inferior wall.
Right. So it looks like LAD, and then you've got the infraseptum and the inferior wall, so it looks like RCA as well, right? So it looks like at least 2 vessel disease, right?
Yep.
Okay. Now there's one other subtle finding here I'm going to show you guys. Take a look at this delayed enhancement image right here, okay? And look at the thickness of the myocardium. How does it look? The
Thin.
black. Right, for some reason that particular image is kind of dark. And also, because if you look at the cine images, at that anterior wall, are the cine images that thin?
No.
Right, so that's one clue. Always look at the thickness of the muscle on your delayed enhancement compared to the cine images. The other clue, look at this 2-chamber view right here, that same location. Let me magnify this to make it easier. What do you see? Right? And again, the reason that oftentimes the long axis view will show it better is because the long axis are done later, and you notice the blood pool now is not as bright. So if you have a very bright blood pool, it can sometimes get hard to appreciate a subendocardial infarct. And that's why you always want to compare the thickness of the myocardium on your delayed enhancement to the thickness of the myocardium on your cine images. So in fact, this person, it looks like he's got multivessel disease pattern, but also there actually has been a occult infarction as well. And this guy went on to get cast, obviously, based on these findings. And let's get past this here. See how well it projects. But who's a cath fellow? Nobody? Who wants to be a cath fellow? Gotta be somebody who wants to be. Who's going to do interventional? What do you guys think? Right, so it's- right. So there's a lot of disease in the LAD, right? Is there anything in the circ system? There probably is some, maybe some minor stuff in the circ system. And then the RCA?
Mid is very diseased.
Yeah, it's very diseased as well, right?
Even proximate.
So these findings are consistent. Basically, there is, looks like at least 2 vessel disease, LAD and circ. LAD and RCA, and there was probably a 70% OM lesion as well. This guy went on to get CABG, and it was doing well clinically after that. Okay, I'll show you another example. This is a patient was referred for a stress CMR for evaluation of chest pain for about a week. This is an outpatient referral. Now, one of the things that we always do, and again, this is the advantage with CMR, is that you can visualize the entire chest, right? So before we actually start doing the stress, I didn't show you this in the algorithm or in the flow diagram, but we're actually going to always do just a set of axial images through the chest. And what do you guys see? Who's doing CT?
John here.
All right, this is kind of like looking at, okay, it's going a little fast, so let me slow it down for you, okay?
It's dilated. No, is
It's
there
a large aorta, what else?
Is there a dissection there?
Yeah, there's a dissection, right?
Yeah.
So the point of this case is, if you're not able to look at the entire chest, you could easily stress this guy and not know. I have no stress images for this person because obviously we didn't do a stress. So this is a person who turned out he's got an aortic dissection is the cause of his chest pain. And obviously the management pathway changed quite a bit from looking for coronary disease. So that's why whenever you're doing a stress CMR, before we do the stress part, the techs always call the fellow or the physician, look at the images, make sure there's no problems with the aorta, make sure there's no pulmonary embolism or anything else before you start doing the stress. Okay, maybe, why don't we stop here because we're a little short on time. So any questions on what we showed so far?
Yeah.
Yep.
Two questions. One is with SPEC. Once in a while we have a scenario where severe multivessel disease appears as a normal SPEC because everything's bad and there's no quote unquote normal perfusion area of therapy, so everything looks normal because in SPEC whatever has the highest count is called normal. Is that phenomenon also possible with the CMR, or is it much less likely to happen?
Yeah, so one is if you look at the data will suggest that it is less likely because you can see the performance. If you look at the area underneath the curve for stress CMR, it's much better even for multivessel disease. Usually not. The reason I think is because even though you have three-vessel disease, there oftentimes is still some heterogeneity in the perfusion. And since we're able to resolve the thickness of the wall, even though you may see kind of diffuse perfusion abnormality, there'll still be some variability to it. And so that's one of the clues. The other clue is that oftentimes in somebody who has multivessel disease, they'll oftentimes have an occult infarction as well. So we've got that delayed enhancement image also that aids us in being able to identify situations where there's perfectly balanced ischemia, because oftentimes there'll be some infarct. So I think the likelihood of missing it is much lower. So now I've seen several cases where the SPECT was normal and then the CMR showed an abnormality present and the person's got three-vessel disease. So I've seen that side. But again, I haven't seen any cases the reverse where the stress was normal, but the stress CMR was normal. But again, you don't necessarily know, what we know. But I think the data seem to suggest that that's less of an issue as well. Yep.
Last question is not it's more for future. Given that we could do exercise, and given that CMR is so good for the right side, should we start looking at exercise physiology function in people who have hypertension? We developed a big center here for right-sided disease.
Yeah.
We're loaded with people with bad PR and everything else. Should we be kind of doing investigation for it to start doing that?
Right. So, so the challenge is obviously is that when you're talking about exercise, you're increasing the heart rate. And so all of your imaging gets harder to do at faster heart rates, right? Because again, it's an issue of temporal resolution. So I think it can be done, possibly, but I think it's going to get harder and harder to do it. So if you've got somebody who's got pulmonary hypertension, you could try to do this ergometer test and see what happens to their LV and their RV.
Some of the images, when you were doing the first lectures on techniques, some of the images that you showed that were somewhat crummy because they were like one cycle only, still look a heck of a lot better than our crummy echo pictures.
Right.
So
Right.
my
But
feeling is that we probably could do some RV physiology.
Right. But remember that those real-time images are about 50 to 60 millisecond temporal resolution, which is fine for normal heart rate. But if your heart rate is going at 130 or 140, 50 or 60 millisecond temporal resolution may not give you a lot of frames in the cardiac cycle, when a fast cycle, right? So I agree with you. I mean, I think those are some of the limitations. I think there are some improvements in MRI techniques which will allow us to do faster and faster imaging. So I think, yes, potentially in the future, I think there may be a role for this. I would say, based on everything we have today, you know, I'd still be nervous, yeah.
The centers that are doing supine by.
Yeah.
A few centers that are working with that.
Yeah.
What are they experiencing? What are they?
Yes, there's mainly one site that's doing the treadmill, that's Ohio State.
No, there's a supine
And
bike there, I'm sure.
yeah, but there's no centers that are doing that per se clinically. The only one that I know of is Ohio State doing the treadmill. But again, all those, if you look at their images, they're not that great. And if you look at their diagnostic accuracy, there's a reason why it hasn't made the front page of New England Journal, because the diagnostic accuracy is not going to be that much more competitive than SPECT or Echo yet. So I think those are all things that, you know, the approach there is they're starting with it and hopefully trying to improve it as the MRI techniques get better. But I don't think that exercise MRI, I don't think is here today. Yeah, yeah. No, and I think that, I mean, that's an area I think, you know, for investigation, I think it's reasonable. I think it's not ready for prime time by any means. Yep. So, and this is what the appropriateness criteria will tell you when you use CMR. So basically, in patients who have intermediate pretest probability of CAD, who have an EKG that's uninterpretable, or patients who are unable to exercise. And I think that's one of the important messages I want to make sure that doesn't get lost. If a patient can exercise, then there's no reason to do a stress MRI or any other pharmacologic test. Exercise is really the best way to go. The other obviously is coronary anomalies. And lastly is risk assessment in patients with a prior test, either based on CTA or by cath, that shows us a stenosis of uncertain significance, and you're trying to establish functional significance of it. Those are kind of the primary roles for CMR right now based on the appropriateness criteria. So, okay, thank you all for your attention.